Hi. We have some sun today in the Bay Area.
Yeah, for the moment.
Yeah.
For the moment is the disclaimer, right?
We have another atmospheric river, which is new in our vocabulary, coming in tomorrow again. I know. How are our friends down in LA doing?
Well, it's sunny here for the moment. I think we're supposed to get a little something over the weekend, but we've been not getting as much as the Central Coast and Northern Cal. But it just depends where.
Well, we'll take it.
Yeah.
I will share while everybody's coming in. I live in Marin County, which gets a lot of water. But just as of yesterday, our reservoirs are 100% full.
Right.
So that I know we haven't seen that in 10 years. There's not much more we can hope for this year, I think.
All right. Well, Timmy, I think we're good to get started. And Angie, we can bring up the slides when you're ready.
Fantastic. Thank you, everyone. Happy New Year. Thank you for bearing with us on the new registration. We're doing our best to keep those Zoom bombers out. So we just thank you for your patience, our resiliency as a team to be able to figure this out. Maybe over time we can lessen it, but so far it's working. If you have any ideas to make it a little bit better, let us know. But we're really just getting the word out. Just email us at info@Connecting for Better Health, and Angie's going to take it from there. It's almost a concierge approach. But thank you, Angie, for all of your work you're doing. And we really appreciate that. And thank you all for, again, being here with us and getting it on your calendar. Going forward, we will have 2 meetings a month. We think that cadence will work for us this year. We will keep you posted of our events and our virtual and in-person events as well. But we are already off and running and have a really great day planned for you today. So let's go to the next slide and I can review our agenda. We're going to go through the governor's budget. Not so much news there, but let's all get on the same page. And then we are waiting with bated breath. There's just so much to be able to go through on the data sharing framework and the stakeholder updates, and Robbie will walk us through that. We're going to focus on the QHIO, lack of a better word, framework or template, and then also give you all an update on the grant making that's going to happen on the heels of the education grant. We are saving the policies and procedures for our next meeting because we really want to have them open to the public so that we can all, dig in and make sure that our comments are relevant and germane. We are also going to go over our 42 CFR Part 2 work at the federal level. We'll send in some comments. Robbie's been hard at work on that with the team. So we really want to make sure that we're reflecting your work as well. And then at 11:30, 11:40, we'll be watching our time. Daniel Stein with Stewards of Change Institute that we've been partnering with this year has, and we've discovered, it's like peeling an onion, how much amazing work that they've done around consent and identification management. So we want him to give you an overview of that work. It's almost a toolkit, if you will, and also marry what we're going to be doing in the state with the consent management pilots that DHCS is kicking off. So I think we want to be able to make sure that we're watching that work with all of these tools in mind. And then we'll end with our news and events. Next slide. We always start, of course, with our vision and policy priorities. This has been updated based on your work from last year. Our vision remains the same, but we are really focused even more honing in on the data sharing agreement. Again, funding. And I think it was really good to be a little bit more crisp about why we're so focused on community data sharing And the work that we've done with our workshops brought this to light with homelessness and aging and soon to be women and children, that we really need to understand to make sure to be that we're inclusive and that social services are also included in our data sharing vision. And then finally, in addition to the data sharing agreement, all of the policies and procedure development and the data sharing framework, and making sure that that hits the 100-yard line soon. So I always also offer for you all to put into chat, introduce yourselves. If you're new this year, welcome. If you are now, we're in our 3rd year from the beginning, thank you. But, this is also a big networking opportunity. So if you could please introduce yourself and your organization, I'm sure folks would want to link with you outside of this meeting. So with that, Robbie, I think I'm handing it over to you with the announcement of the data sharing agreement and the opportunity this week or next week, I guess.
Awesome. Yeah. I think if we could move to the next slide, I think just to reiterate, as we did last year, those 7 ingredients that we outlined in a fact sheet last year around successful data exchange, what we think is needed, and I think all of this and even more has been captured in the data sharing agreement and the policies and procedures. Everything from standards to understanding how to engage patients and consumers in the sharing of health and other information. And then additionally, as Timmy mentioned, I think we'll continue to focus on social services, but also on immunization and COVID use cases, and continue to focus as well on public health data modernization. I think we'll touch on that, when we get to the budget too, when it comes to funding and the work that the state is doing around public health data. But on the next slide, just a reminder for folks, in case you're new here to Connecting for Better Health, we've been super focused on what California Health and Human Services has been up to. And I think a key piece of that is the data sharing agreement, as we've been tracking. So for folks who maybe haven't been as up to speed, the data sharing agreement signature portal is live, and specified organizations have until the end of the month to sign it. That includes most healthcare providers and health plans as well. Clinical laboratories are in there too. And on the next slide, in case you are curious about learning more and maybe haven't had time to tune into Cal HHS webinars on this topic, there will be a brown bag session hosted by America's Physician Groups next week. Just to recap, Connecting for Better Health and the Blue Path team is working with Transform Health, our partners there, and with APG as prime, with several other associations throughout California, on an education grant provided by the state, focused on spreading knowledge around the data sharing agreement and what's in it, helping to highlight for the state as well any issues or concerns constituents have. This, kind of first event that we're hosting will really be focused on how you can sign the data sharing agreement. APG will also have several of its members there. So representatives from medical groups who've signed the DSA to share out why they've signed it at this point, why they think this is important, what their experience was like. I think so far, as we've heard, it's a pretty easy process. And I think, as the state told us this week, over 100 organizations have signed so far, which is great to see. So please register through this link if you're interested in joining. So moving on to the next slide, we wanted to provide folks with an update on the governor's budget proposal. So by the 10th of January of every year, the governor of California has got to put out their proposal for their budget priorities in the coming year. I think, as many of you know, California's tax revenues are not as high as they were in past years. So there are some areas where, the state has indicated cuts. But, overall, when it comes to health and human services, there's, $230 billion in there for HHS, with a significant portion going to DHCS, which administers Medi-Cal. There's no mention of funding for interoperability data exchange or HIE projects in particular. But that's not to say that, the major programs that we've been tracking are not being funded. Many of them had their funds appropriated in past budget cycles. So the DXF work and the education grants, those will continue. The ePulsed work that was funded 2 years ago, as well as the population health management service that DHCS has procured. So all to say, we'll continue tracking these efforts and the policy as it comes out. And I think as well, we are anticipating, trailer bill language at some point from CalHHS around governance and enforcement for the data sharing agreement at some point. That could come out this spring, or it may get slipped into a budget trailer bill after the budget's passed this summer. So we'll continue to track those developments. We may also see a policy bill arise in either of the Assembly or the Senate this year too. So I guess I'll stop there. Any questions folks have about the budget at all, or the process, or these efforts that we've been tracking? All right, well, we'll continue to keep you all updated there. Moving on to our next slide, we wanted to touch on data exchange framework updates with you all coming out of the latest implementation advisory committee. I think to start with here, a big focus of the conversation this week at the DXF IAC meeting was on QHIOs and the application that the state's putting together around QHIOs. So for those of you who maybe couldn't make the meeting or view the materials, we'll drop the link in the chat. But at this point, the state's really given an overview of, kind of introductory pieces of the application, specifically around organization information. So things like financials and organization name, where they're incorporated and such, as well as privacy and security questions. And I think a key missing piece that's to come is around functional requirements. And we'd love to discuss that with this group in a moment around how, we might provide some recommendations to the state. But in terms of feedback that was provided at the meeting, a couple key topics came up around qualifying HIOs. So these would be the entities that the state designates as, an organization that someone who signs the data sharing agreement can go to help with their data sharing obligations under that agreement. So a couple pieces came up, one around data quality. How will the state potentially, monitor, certify in some way the quality of data that gets shared between by QHIOs on behalf of signatories? The financial requirements came up. They did bring up that they'd like to see QHIOs have 6 months cash on hand, and some organizations, share that might be kind of a burdensome requirement. Another big one that came up was, equity and access to QHIOs for all signatories versus QHIOs potentially only serving a subset of signatories. So that could be just providers or just health plans and the like. And then lastly, just around privacy and security, really asking for a CDII to spell out the privacy and security requirements versus kind of just asking for, what a given organization's priorities might be. So we'd love to hear from you all, especially I think our friends in the room who are HIEs and tracking this closely. What are your thoughts on the QHIO application? We're, I think, particularly interested in the functional capabilities, requirements for HIOs. What can we do as a coalition when it comes to providing some recommendations to the state as they continue to build those out? I think especially with equity and, being able to serve all comers in mind. But would stop there and see, I don't know, Felix or Dan, I see you on video. What are your thoughts, especially on this topic?
Yeah, I certainly have thoughts, but I've spoke a lot at the actual IAC. So Dan, did you want to maybe hum a few bars if you're so inclined?
Sure, happy to. Thanks, Felix. Though I really want to hear from everybody else, and I don't want to sway anybody's presentation if anybody else feels strongly, but no surprises. I think it's all doable. Yeah, sure, we have a few concerns. John Helby's just joined from Sac Valley MedShare. He was also on the call. So I think it makes sense. I think, there's a big unknown between our existing HIEs that work in the state and have relationships and new entrants. And I'm sure, that's everybody's unknown as to who will be entering the state as a qualified HIO that haven't traditionally been here exchanging data. So again, I think it's all fair. I think it's doable. It's not without cost. It's not without change, but I think it's doable. So I am cautiously optimistic. And John, I don't know if you want to give your observations or back to Felix.
Yeah, I'll give my observations. I think, the one thing I think that we're trying to do is trying to slow them down with regards to, strangling the HIOs with more and more regulation without any financial support, I think is the big key, because we have to go and meet all these criteria of, a high trust certification or ENAC certification, or go through the administrative burdens. It's not something that we as nonprofits have a lot of revenue or monies to go and have increased expenses. So that's one thing. The other thing is it was the changing of the slides just took my thought, so I apologize. But all in all, I think it's all doable, and we're very much in line and support of that. But funding and timing, and really building off of what we've done with CalHOP and the EMS grants of the past couple of years, continue to build on that and not derail the progress that we've made.
So that was one of my questions is, I keep going back to this, like we had CalHOP, it was successful. And I guess my understanding is that they want to go further than CalHOP, but why not use that as the initial template?
It's a great question, Timmy. I think to John's point, they overreached a little bit getting to the QHIN qualifications, which is a national qualification. And so there's a little bit of overreach there. And, I certainly support what John said about backing them down a little bit, because this is our state entities who are not trying to make a national play, right? We're very focused in our communities and our counties and our regions. So I think they're trying to be consistent with national standards, and there may have been a little bit of overreach there.
Yeah, Dan, I'm really glad that you made that comment, because it's a really good segue to the point that I would have reemphasized, which is the point that I made that you captured essentially in this third sub-bullet here, Robbie, about equity. There's no pride of authorship, because I think the view that I expressed is one that has a lot of buy-in from a lot of people whom this is all about at the end, right? The end users, the stakeholders, the patients, the Medi-Cal members, the CBOs that serve them, providers certainly, and the health plans that are in charge of this brave new world of CalAIM and managing whole person care and population health. None of that is possible. None of that really gets to the crux of the equity principle of serving all DSA participants if you have criteria that are kind of like the inverse of what Dan was talking about. Like, yes, national standards are maybe kind of like a tough fit for state-based HIOs in one regard, in terms of just scale, but on the other end, national standards don't speak to all of these priorities that California is pursuing, with that need data, that need information flowing, and at a high quality and consistency. national standards don't speak to the need for networks to serve all treatment, payment, and operations as one example, right? Not just treatment, which is kind of the status quo under some of the, again, out of state, networks that a lot of people think about outside of California's HIOs. I think the point I'm just trying to get across here is that when we think about the opportunity for this coalition, a really key opportunity and a time-limited one, to have our voices heard and to send a message to the agency as they finalize their Q-HIO criteria, is that they really need to not lose sight of the need for, above all else, like Q-HIO to be able to serve all participants and all required purposes that are laid out in the DSA policies and procedures. That means, treatment, payment, operations. That means being able to serve health plans, not just providers or ambulatory practices or hospitals. You can't pick and choose. You really have to be situated to be able to serve all of the potential and important signatories in the DSA, public health plans, and of course our social service partners.
I see Jessica from Mention on. I'd love to have her thoughts, and everybody else's too, for that matter, as to how you all reacted to what was presented, please.
Thanks, Dan and Felix and John. I just particularly want to underscore John's comments about adequate investment and time in order to meet some of the criteria outlined. Engine has a very strong footprint in the region that we serve, and some of the things outlined would require, capacity building on our end, and just appreciate the advocates in the room with CDII and the state sort of raising those issues on our behalf. Thank you.
So my big takeaway here is that the QHIO, and I don't know if this is going to be staged over time, but that it must have the capability of ingesting and ensuring that it gets and make available social services data that would then follow through with CalAIM, using that. We always go back to that use case in public health. And I mean, that is a fairly big leap for many of the HIEs in the state. Am I correct? I mean, it's just, I know, Dan, you're saying, I mean, I think you are going down that route, but, is that more of a, I mean, do we see an area where the QHIO will be at a community level, community exchange level, where social services data is, and then the national networks and maybe some other networks would be like feeding into those? I'm trying to figure that out. Like, and maybe it doesn't matter, but.
Oh, it matters. It's a great question.
Am I being very clear?
It's an excellent summarization of the challenge. But, we're
all on the same page that
right,
in order
right.
to meet the needs of the data sharing framework and the legislation, we must include social services and social data.
Absolutely.
Absolutely.
And the fact that
I see thumbs up everywhere.
The fact that US CDI version 2 incorporates those data elements doesn't solve the problem, to your point. Yeah. What we're not doing is really framing the problem correctly as to how to best make this happen. And where is the best area to make this data available? It's temporal. So real time is absolutely key as it relates to social determinants of health, not minimizing the clinical need for real-time data. But the fact of the matter is these situations change. And so I need to have the best real-time view of an individual to make decisions and provide the very best care I can for that individual. So we're not addressing those issues quite yet. We're just saying make SDOH data available. That's all we're saying. So we have to dive a little deeper into what this use case is and how we make the best presentation of this data.
And it's a very complex situation when you get down into the weeds of everything, when you include CBOs and include county public health, behavioral health providers. in a region, or, you know, you have regions that want to spin up CIEs, and, you know, if we're not careful in how we approach this and do this, we're going to wind up with 48 different CIEs that have to be integrated with HIEs in order to really truly do whole person care.
Mhm.
And that's where it gets complicated. And then where do the payers come into play? I mean, you know, if we don't do this right, and we don't provide some infrastructure support for HIEs, QHIOs, and we don't make it, and we make it too strict going in to become a QHIO. There's nothing wrong. None of us argue with the evolution of where it is we need to go, or, you know, how we evolve. We all need to know that we need to evolve and continue to do that, but we need to do it in a sustainable way. And I think that's where we got to really kind of draw the balance to this is CalAIM and the data exchange framework are both ahead and behind of what we do as HIEs. We're already doing a lot of things as HIEs that are in the data exchange framework.
Right.
But there's a lot of initiatives out there that are competing with us, like BH Quip, you know, and other CalAIM initiatives, and then connecting payers and to data, and as much as we think the payers are ahead of the game, payers are not ahead of the game. We're in the same boats as a lot of people, and we're all trying to catch up, and we don't want something to be built so strict that it doesn't allow us to grow and evolve and meet the intent of the data exchange framework.
That's a good point.
Yeah, John, that was, I couldn't say it better as usual. I think that really goes back to, you know, obviously, you know, you always put it up every single meeting to me, but that principle, that priority of funding for this coalition, for this group remains, I think, you know, top of mind. And I know we just went over an overview of the governor's budget where there wasn't a whole lot happening. It was kind of, you know, stay the course and under sort of a, you know, uncertain revenue environment. But, you know, from an advocacy standpoint, like, I don't think we can afford to take our foot off the gas pedal. Like, the state has done many great and promising things with the DSA. Sustainable funding plan for the infrastructure to make the DSA successful is not one of them.
Not there.
To be all candid, and we need to, you know, obviously, I think, rev up that push in the education in the months ahead as the legislature reconvenes and you know, begins crafting its budget with the administration. So,
And the timing is now,
yeah.
correct? I mean, the timing is
Yes.
over the next 3 months with the legislature.
Yes.
And
Yeah.
I think
that's
it's
something that I think we talked about last year of being more present up in Sacramento. So if there is, you know, I'll just look for all of you. If there's desire for us to do some office hours up there, we'd be happy to make those appointments and, you know, take folks in and do some education. So follow up with us. Let's do it.
And I guess not to jump too far ahead, because I know we're going to get to the grants in a minute, but I think there's a link to that too in the discussion.
Yeah,
that was
that's the hit. That's the linchpin. Yeah.
You know, the maximum funding amounts for stakeholders, whether they choose a QHIO or not, right? Because you ultimately don't have to choose a QHIO, but even I think for the TA grants, like you know, they're much lower than even CalHOP was to onboard to an HIE. I think for hospitals, for example, it's a third of what was offered under CalHOP. So it does.
And Robbie, I'll add to that point. I think it's very inequitable for smaller counties, smaller provider groups, because they even cut that in half, right? And for HIOs and for those people, it doesn't cost them any less than a 15 or 10 or 15 or 25 provider office to connect. Those costs are the same, but yet they're going to get less money, which drives inequity, right? Because people that have come together as provider groups are getting more money, and there's questions about, is that enough money? Number one, as you pointed out with CalHOP, but number two, if you're 10 or less, then you're only getting half of that. And that's a big problem, because there's no difference in the onboarding cost, fees, and time, effort, energy, and expense. So that's what I think really kind of needs some voice, especially as it relates to the grant. Before it finalizes and before it comes out,
Yeah.
we got to get that to be equitable, or we won't make the big transition of getting more providers onboarded.
I have a few things. I'm just looking to Robbie in terms of the QHIO application and the qualitating these qualitative of where they're going. What is the timing for us to get our voice back? And how should we collect that? Should we draft something and then get input? Do you need another meeting for us like we did with our
I think
our,
we can circulate a draft with folks, and I think we've had some really good discussion here on features and functionalities, and then in the chat too around security, which was discussed at the meeting. And so I think we could probably focus on those two items. In a briefish letter to CDII, just providing some feedback on the security topic, but also then functional capabilities for QHIOs. And I guess just to note too, we can also make sure to note too, I think one thing that hasn't come up is just like, what are the requirements for the data that has to be shared for participants? And I think for a lot of entities, it's maybe more than they're sharing today, right? Like a designated record set for a provider covers more than just than like clinical PHI, right? It's claims data potentially too, and other personally identifiable information that's not PHI. And can EHRs today do that, or do we need larger entities that can do that? I think just to point some of those items out for CDII so that dots are being connected as they look to qualify HIOs, and like, what does that mean? Whether it's a nonprofit HIE or other industry vendors, right? Like, what are the features that they need to make sure they're focusing on, I guess, as well. So I think I would just raise that as another point that we can bring up to make sure they're tying it back to the PMPs and the DSA and everything that AB 133 and CDII have promulgated.
So Robbie, I agree. I guess I'm looking at timing and when can we, how quickly do we need to move with this group? Do we need another, meeting to kind of get that drafted, or you want to take a draft that get it out and then we can do
it and share next week. And then if folks feel like we need a meeting, that's we can totally do an ad hoc. I'm not sure if that's needed, but totally happy to if folks have a lot of questions or feel like we need another discussion. But I think we can be pretty like succinct and to the point in a letter.
Fantastic. And Stephen, I thank you for joining us today. I also am really kind of want to make sure we highlight the idea of data quality. And I'm just going back to the presentations we've heard from our friends in Michigan. I don't know about all you, but I was blown away of how they've been able to incentivize data quality over the last few years after they started on their journey of incentivizing data, and now they're getting to quality. So maybe we can highlight that too. And it also ties into funding where, we need all hands on deck to be moving the same way of how do we incentivize data sharing and also data quality.
I mean, I love the idea of data quality as a focus for us in the state. I mean, it's as I've mentioned, both in the earlier meeting and today, they're not standards against which we can judge data quality. I mean, there was recently a document put out that has some really good ideas in it and lays out a roadmap, and there will be more work done on it. But I think I think if we can figure out a way to incorporate that or some other accepted, measure of data quality, it'd be wonderful.
Excellent. We'll add that to the list.
One other area too that's in the chat, and boy, I'm feeling it too with the cyber insurance insurance. That could also be something, and at least bringing it up to a regulator too, to their attention.
Yeah, I would just offer from the standpoint of the healthcare Sector Security Council that we're starting to look at it more from the standpoint that insurance actually complicates your risk assessment and risk mitigation approach, mainly because things will get pushed off as saying, well, we have insurance to cover that, but not really necessarily understanding the overall impact and risk of what that might be. And to the point of the conversation, you know, risk insurance premiums are now going through the roof because of just the degree of problems we're having. Just like I use an example, my own personal difficulty is getting wind insurance here in a hurricane zone. You're just getting priced out of the market. Insurance won't cover it, but they won't offer the policies, and they'll just drop you. So I don't think it's an effective consideration for a cyber strategy in the future.
No, and having it written into the requirements of a QHIO, it makes it difficult too, because the insurance companies are getting more and more complex in them granting cybersecurity insurance, number one, and number two, it's going up exponentially in cost to where we can't afford it. You know,
That's an area that the state could come in and mitigate, right? Through
yeah,
like an earthquake fund.
Yeah, we need some attention there.
I agree.
For sure, because it puts us more and more to where we can't sustain that level of increase, and they're driving complexity as well. Like, you have to meet certain criteria and you have to do certain things in order to even get qualified for the insurance, let alone pay for the premium.
And then that'll get promulgated too. I mean, I'm sure some entities will promulgate it to their trading partners. And all of a sudden you're asking the same level of cyber insurance for a CBO, which will just stop everything in its tracks. So. Anyway,
yeah, but I'd also add as we march forward with digital health and electronic health into the rest of this century, that more and more of that is critical infrastructure. So what we weigh within the sector as we talk about it is insurance is great if you're covering business loss or compensating for a regulatory fine or something. But there's already debate about whether or not people have died or haven't gotten care because of a ransomware attack. It's irrelevant if there's insurance, somebody didn't get medical services. And if HIEs and e-health exchange, the concept, not just the organization, play more and more of a role for that in the 21st century, then as critical infrastructure, your insurance doesn't matter. You need to be able to move data around for people to get care.
Agreed.
All right, well, we will make sure to add cybersecurity and insurance in there too. I think it's a great idea and something that really wasn't discussed yesterday, or 2 days ago, I should say. Well, I think just moving to, so I guess just to wrap here, we'll make sure, I mean, I've got quite a few notes here. We'll draft a letter. We'll circulate that with all of you. Would love your feedback. And if we need to schedule another call, you know, sometime next week, we're focused on and we can talk through items. You know, just to sum up the other piece of the implementation advisory committee meeting was really around the grants that CDII will be putting out and has awarded to. So as we mentioned last time, education grants have been awarded. That was a $2 million pot of money that was awarded. And as we mentioned too, you know, we are working with the APG multi-association grant, as well as 5 other trade associations that are under that umbrella. And several other trade groups have been awarded education grants too, including the Medical Association, the Primary Care Association, and others. But really the focus of the discussion was around the QHIO and TA grants. That'll be a total pot of money right now of $48 million. You know, and organizations can kind of choose the path or paths they want to go down in terms of drawing down funds. So the QHIO grants really have to be utilized to onboard to a QHIO. Those funds can be shared with the QHIO as well, and funds will flow through the QHIO. And then the TA grants can be used to, one, you know, develop your strategy, figure out if you need to join a QHIO, or be used to procure or pay for, you know, services from another vendor who can help you meet your obligations under the data sharing agreement. The funding maximums range from $7,500 to $50,000. And there'll be at least 3 funding rounds with a stated initial priority around the mandatory signatories. There was discussion around, allowing for others, including counties, to maybe get in early to draw down funds. And a lot of discussion around, the funding amounts being potentially insufficient as they're currently stated in the draft meeting materials that were released. Yeah, Stephen, great note. Like, what's the denominator? I think they are all trying to figure out, what is the denominator of health systems, providers, health plans, counties, who potentially need to sign the DSA. And it's pretty sizable, and would think 48 million probably won't cover everyone and everyone's needs, especially when we compare, I think, these funding levels to even just CalHOP and what was offered to hospitals and providers under that incentive program. It's about a third here in terms of the funding maximums that would be allowed.
That's what we were hoping to stand up. So as part of their data sharing agreement, educational grant that Connecting for Better Health was awarded with APG and several other partners that are here today, we are hoping to stand up a new webpage on our website that will have all things data sharing agreement. And we would love, once the state makes transparent the signers that are already stepping up, for us to start tracking where we are against some kind of baseline, some kind of goal. And I think the state will, I'm hoping that they do that, but I don't know if they're going to go, go down that kind of path. But I would love to be able to have some place where we can analyze who is signing, who's not signing, what is our goal, and like all be kind of really focused on getting there. So look forward to that. We're struggling though with that denominator, but we can come up with something.
Yeah, and I guess just as an update too, at the very end, CDII released, that 159 agreements have been executed, 34 are in progress, and then a total of 289 accounts have been created. So they have been making progress on getting signatories, but yeah, I think again, to Timmy's point with education grants, that'll be something, especially we'll be working on with the associations that are part of the APG association grant, is figuring out the denominator and, conducting educational outreach to those who haven't signed to understand what questions they have, how we can help troubleshoot those with CDII.
So I want to go back to, Robbie, if I can, to this conversation we were having earlier about not enough, just, dollars for this infrastructure. And this is super clear. And the first thing that came to mind when I saw these numbers is, why aren't we getting a match? Why isn't CDII all about figuring out how to match these funds with federal funds? And I know with those of you with experience doing that, is it worth raising that flag really quickly? Or would it take us another 2 years even to get 50 million out? Like, what is the give and the get on that?
I think the get is potentially very, very valuable to me.
Okay.
I strongly think that we need, they probably have heard it before, but it obviously has not obviously yielded the intended effects. So we should definitely not shy away from impressing it upon them again. And kudos on the paper. The blueprint was great.
This is a state as large as California, and you look at states like Florida, Texas, Michigan. They've all been able to be successful in matching these funds. I think CMS is ready for, maybe we should reach out to CMS Region 9 and say, what can we do to be able to make your voice heard even louder? But why aren't we figuring out how to match this? Might have to ask John at our next panel meeting discussion. Dan, good question for John. All right. Well, that potentially needs to be something that we raise up to John really quickly. And maybe for those of you that are on the advisory committee and the implementation committee, you can bring that up as well.
All right, I guess just one other policy item we wanted to just touch base on again is just on the proposed changes to 42 CFR Part 2. So regarding substance use substance use treatment data and how it has to be handled, consent procedures. I think as many folks know, for a long time, they've not been in alignment with HIPAA. In the CARES Act that was passed during the pandemic requires SAMHSA and OCR to more fully align in many ways 42 CFR Part 2 with HIPAA. What we'd love to put together, I think some brief, but generally supportive comments around 42 CFR Part 2's proposed changes. We put together a table here of just some of the key areas. I think really putting on our hat around data sharing, what could really facilitate, while also recognizing that we do need some added protections for substance use treatment data. Thinking about what's needed here in California, what we've heard from you all. So just to give a brief summary of what's in here, I think the key proposed change is really around patient consent and redisclosure of records. This rule would, allow for individuals to provide a single authorization for all future TPO uses of their substance use data. So, they can specify general classes of people. They have said that they'd like for, specific names of intermediaries that might be used. So that could be an HIE or an EHR vendor. I think this is a big change from the status quo where you have to provide an authorization each time data would get shared. And there's some specific redisclosure provisions depending on whether, the entity receiving the data is a covered entity or not. But really, I think brings these standards more in line with HIPAA and really allowing for data to be shared for TPO purposes. Another key one on here around, restrictions on permitted disclosures, permits programs to allow folks, if they want to, like under HIPAA, to not have their information shared. This is optional, but again, in line with HIPAA. Notice of privacy practices, again, just bringing these standards in line with HIPAA and not calling it a patient notice anymore. Breach notifications would also be in line with HIPAA. And then, they have asked stakeholders, should we, similar to HIPAA, create a definition of psychotherapy notes and have that data that falls under Part 2 also be subject to just certain heightened protections similar to HIPAA as well. So would be curious if folks have any thoughts. We'd love to draft I think a pretty concise letter generally in support of these changes, but curious if folks have any other thoughts. Revise HIPAA while we're at it. Well, I'm not sure
Let's do it.
Yeah. I think that's another letter and another conversation with CR Jim, but
but I do agree that CMIA Act does need to be updated, and we should make sure that we do a copy of our letter to someone at the state, be able to give them a heads up. Maybe John.
Okay, great. Well, we'll follow up with folks on that, and would love your thoughts, love your input.
What do you all think? Has anybody else done a deep dive? And you want to share your comments? Are you going to be submitting comments as well?
Well, I see comments in the chat around state laws. I think, neither Congress nor OCR has, said that they believe that these laws preempt any state laws. I think that's a whole nother contentious issue. I think that's also been holding up privacy law changes in general in Congress, as we've been tracking those, and that effort that California lawmakers are very intent on making sure that there's no preemption. But not to say that that's not an issue that we can, revisit as a coalition too.
Any other areas here that you're seeing we're missing? Any disagreement? Love the chat. All right, so I think we're a go with this. So the draft letter will go out, Robbie, next week.
Yeah.
And then we will be submitting it on behalf of the coalition. Okay. And you can absolutely take the letter and put it under your own letterhead as well. That's what we've done in the past, if you want to send in something in addition.
Yeah, or if just putting this out there too, if your organization is submitting comments, like would love to collaborate or share ideas. We're always open to that as well. All right. I guess moving on, and Christine, I see you're on. We'd love to give some time to our partners at Stewards of Change and the National Interoperability Collaborative to share out some more about the materials they've developed around consent and consent management. So Christine, I'll hand it to you.
All right, I guess Daniel isn't on, huh? We were in the same meeting and I'm not sure why he didn't end up joining, but that's great. So yeah, I know, I think we have a few people here who are deep into Stewards of Change in the National Interoperability Collaborative. I see Jim shaking his head. But for those of you who are not as familiar, Stewards of Change has been around for about a dozen years or so, but has really been focusing, deeply on interoperability from a technical and a policy standpoint in weekly meetings that have been occurring for the last 3 or 4 years at this point. And 2 years ago, held a virtual meeting that was supposed to be a meeting there at Stanford, focusing on equity and other issues, and came out with a laundry list of these are things we really should work on together and try to solve in the relatively near term, or at least get started a serious effort on them. And at the top of the list was consent. And that was because of the experience of so many people from around the country and even a few international participants in having put together really cool interoperability projects, with different aspects of human services, education, etc., and having had them be stopped dead in the water because the consent was not there. And so, it didn't matter that you had solved the technical problems of data exchange, which are challenging enough, but without the appropriate level of consent based either on very clear law, we're just talking about 42 CFR Part 2, or on policies, because in a lot of areas, particularly around human services, the laws are not as clear as they are in medicine. And then, we also have a lot of other healthcare that's not medicine, right? So a lot of community health programs, non-covered entities, et cetera, where again, it's not super clear, what happens, for example, with the records of a mom and child taken care of under the nurse family partnership or other maternal child health home visiting, WIC, other things like that. Again, just not as clear. And so, of course, the best approach to this when the law is not clear is to have a very clear informed consent. And when, of course, there is very clear law, whether that's federal, state, or county, as it might be in California, that the consent, of course, needs to be compliant around that. So we've been meeting, really focused on consent and related issues for the last year or so, and are, looking to encourage proof of concept projects around the country where to build what we like to call a consent service utility. Not everyone, quite, uses that language, but the idea being that, like our, power utilities, other utilities that we have, and maybe some of you are hating yours because there's been a lot of power outages recently, but there's a place where where you can find the consent. There's a consistent home for consents where consents are stored. And there also is that potential that consents can be executed using the same tool. So at a minimum, you have a record that a consent was done, that it is currently valid, it hasn't sunsetted, et cetera, so that that information can be moved. And then a more sophisticated version of it allows consents to be, like the blank version of these consents, to be stored there in that utility and actually completed in that utility electronically, or downloaded and, you know, done on paper and scanned back in, God forbid. But whatever needs to be done so that you can have equitable access to it, regardless of what population that you're working in. And then of course, the third level is this consent utility has the capacity to connect to the various different systems that would be sharing information, and to be able to move that information or to open or close the gates depending upon what the consent is for, and so that the information can be triggered to be shared or not be shared. And, you know, we've also given a lot of thought to data segmentation and tagging, and, you know, that the baby step is there a general consent, but the, you know, the future state is that there could be a very, very sophisticated and granular consent as well. I see that Daniel has joined us now. So that's been, you know, one of the areas of focus has been very much on trying to work with different communities around the country, very specifically on consent. So let me just mention a couple of pilot projects that we're working with. And I know we've had conversations with some of you there in California about potentially being other areas where we could work on this as well. But just to give a flavor, one of the projects we've been working on is in the Bronx, New York, with a CMMI project called Integrated Care for Kids. And Integrated Care for Kids was the first alternative payment model project to come out of CMMI focused on the pediatric population. You know, there's been tons and tons and tons done for, you know, obviously Medicare, but also the dual eligible and older Medicaid folks who are very sick and big high utilizers, but not been a lot on kids. And so they defined what they called a series of core child services that needed to work together for this project. And there's 7 awardees trying to make this happen around the country. None close to California. Oregon was in, but they dropped out pretty early on. And so, you know, the need to have interoperability among these core child services is what's driving that project. And so our specific project there is with early intervention, which for those of you who are not familiar, it's the part of the Individuals with Disabilities Education Act affecting the preschoolers, the 0 to 3-year-olds. So this is what happens when either a parent is worried about their child's development early on, or the primary care provider or the daycare provider, somebody's worried about this kid and their development, and they have access to a huge number of services to, you know, get them on track so that by the time they hit those school years, you know, they're as ready and able to learn as possible. And, you know, this comes out of education because we don't have universal, you know, healthcare coverage for kids in the country, although, you know, California is pretty close. And I live in New Jersey, and we just copied California this week, and we now have Medicaid for undocumented kids here too. But the
Christine,
bottom line,
I just want to give you a heads up that we are at noon right now.
Oh, sorry.
No worries. I hate
Not
to
paying
put you off,
attention.
but this is what happens when we have our presenters come in at the end of our call versus at the beginning. So I think if just with time, is it okay if I send people to your website and to the materials that are there, and then we can follow up with you and Daniel to see if we can continue this conversation in one of our next calls?
Yeah, that would be great. And so we would welcome people to join the National Interoperability Collaborative. There's tons of materials there, and we can
Can you
certainly
put that in the chat?
talk more about that. Yes. So
Yeah, and we have a
Daniel,
Wednesday afternoon call that everybody's welcome to join too. So
yes, every other Wednesday now.
Well,
So,
and I think that we're really so welcome to learn about all these resources. And as the state is going forward with or DHCS is going forward with their consent pilots, which is like pretty basic from what we can tell, let's make sure that we're taking advantage of all this other great work that's being done, and how can we use that money and that experience to leapfrog our work. that's the plea that I would make for all of you that might be involved in those pilots. And Daniel, Christine, you want to give us some last words there?
I just sent you some slides that have different resources in them and links. So if you want to send it out to people, there's the NIC, which Christine put in there, but there's also some toolkits that we've done in the past, as well as the most recent kinds of things, links to the, there's a lot of resources there. And then there's one page that has a lot of resources around different components and aspects of it. Folks have probably seen some of those already, but feel free to share that around to folks. It's not the most elegant slides, but it gets the job done, I think. And we're happy to come back and talk more because
I think we need to.
Yeah, no, and just the thing, I don't know if you mentioned this already, next in 2 weeks on the 25th. Did you mention the 25th? So we have our partners at the Network for Public Health Law, who are an RWJF. So they're going to do a deep dive into the 42, the new policy, the new rule for the 42 CFR. Yeah,
Specifically around consent focus.
specifically around that. So feel free to, and there's a note in there, but you can also send that around to folks if you want to put that on your calendar, because it should be a pretty good view of how HIPAA and 42 CFR are coming together in really powerful ways. Okay.
We'll do that. I'm going to let folks get to their next call. Thank you for joining us. Take a look at the deck, because there's other announcements and news.
Yep.
Meetings to put on your calendar. Will include this new work from Stewards of Change. And we also will send out our deck as a PowerPoint too, so you can use it with your colleagues. So thank you all. Have a great day.
Thanks, everyone.
Bye, everybody.
Bye.
Bye, everyone. Thanks.